endoscopy procedure for central review and scoring. Endoscopy, and colonoscopy in particular, provides important visual information about inflammatory bowel disease activity and severity. Endoscopic image interpretation is carried out by the central GI endoscopy specialists, who review and read video images obtained in the course of the clinical trials. Centralized endoscopy reading is associated with some challenges. Quality of the recorded endoscopic video is highly dependent on the performance of colonoscopy by the site investigators. Insufficient wash-in and inadequate insufflation may jeopardize the visibility of the bowel mucosa, and lead to misinterpretation of the images. The video may also suffer from a large number of uninformative frames, due to fast motion, or out-of-focus imaging of the endoscope, and frames with large specular reflections. The presence of these uninformative frames may lead to inaccurate assessment. Standard training of the site investigators may improve the quality of the video, and provide better qualitative and quantitative assessment of disease activity. Although the endoscopic procedure is recorded entirely, from endoscope insertion to endoscope withdrawal, the scoring is performed on endoscope withdrawal. Withdrawal should last at least 6 minutes. 5 segments of the bowel are evaluated and scored: terminal or neoterminal ileum, right colon, transverse colon, left colon and rectum. Landmarking is performed during withdrawal phase, starting from the terminal ileum to the rectum. Each landmark indicates the beginning of the segment, and should be entered into the laptop. Every attempt should be made to intubate the ileocecal valve or anastomosis, and evaluate the terminal or neoterminal ileum. After the endoscope is advanced as far as possible beyond the ileocecal valve, the video should be paused. Biopsies may be taken when necessary. Recording should not be stopped when taking biopsies or removing polyps. Meticulous examination of the bowel mucosa should be performed. Appendiceal orifice should be visualized when present. Visualization of the appendiceal orifice, or ileocecal valve, indicates the beginning of the right colonic segment. The landmark times should correspond to the beginning of each segment. The tip of the endoscope should be positioned and maintained in the correct axis at an appropriate distance from the colonic wall, in the middle of the lumen. The views of the mucosa are always better when the colon is fully distended with air. The endoscope should be withdrawn slowly. Washing helps to differentiate ulcers from exudate. The rectum should be properly examined. Retroflexion in the rectum should be routinely performed, unless it is contraindicated. We would like to thank the site investigators for working with us to ensure high-quality videos for central review.